What often comes as a surprise is that the number of people who die from cancer worldwide is greater than the number of people who die from AIDS, tuberculosis, and malaria combined. Unfortunately, this will soon become true on the African continent as well.
In a perfect world, every African who developed cancer would have odds in their favor.
We don't know how many people die from cancer in Africa because in very few countries in Africa is there existing a medically certified cause of death scheme.
They think cancer is a foreign disease, does not exist here.
Between 90 and 100% of women with breast cancer in Africa presented with stage 3 or stage 4 disease, advanced disease or metastatic disease, where cure is not an option and you've got to treat the symptoms and provide palliation.
Because the majority of people all over Africa, 50% of Africans never see a health worker. Now, if you go to a conference, the doctors speak as if everybody goes to the hospital, and they don't. In cancer in particular, less than 5% actually reach cancer therapy. And so 95% of them are going to die in the villages, usually without any pain control.
Tobacco causes, in Africa, probably more than 40% of the cancers.
The tobacco industry is looking at sub-Saharan Africa as an area for growth. We actually need to combat that.
Tobacco, though probably the worst, is not cancer's only enemy.
When you talk about poverty, the first thing that comes to your mind is food, clothing, and housing. Those are the 3 basic needs. Health is never a priority. Poor people are interested in current survival. They want to survive now and not in future. They don't want you to tell them about prevention of a disease that will occur 20 years from now, for example, or that will spread and kill them next year. To them, hunger may kill them this month before the cancer kills them next year.
Unfortunately, the list of obstacles to the fight against cancer in Africa is longer still. Stigma, myths, even the uninformed advice of traditional healers continue to play an active role in African society.
Cancer in Tanzania is still equated to death sentence. Sometimes people are not wrong to say so, because if all cancer patients die, how can you convince anybody that it's not a death sentence?
No, we do not have enough oncologists in Kenya. We have only just about 8 oncologists in this country, in a country of about 43 million people. Yes, just 8.
It is clear that there are too few oncologists in Africa. The question is, how do you train enough of them quickly?
But if you take nurses, you take technicians, you take doctors out of their country to train them in a high-resource country, our experience is a large majority do not go back to their own country.
Which is why we have set up our program here locally. It's a lot of work, as I said to you earlier. It's an awful lot of work to do this, and it's expensive.
I have a number of applications on my desk now from doctors who want to train in oncology. But the one thing that they don't have is funds to take them for training.
As with most things modern, having the right people is critical, but so too is having the right equipment. In the case of cancer, no single piece of equipment is more important than a radiotherapy machine.
There are 30 countries that don't have a single radiotherapy machine. There are countries where they've got one radiotherapy machine and you go and visit it and it's broken down.
How many radiotherapy units do you have?
We have 1 radiotherapy unit.
So not having radiotherapy means that patients are suffering very much because of pain and other symptoms due to the cancers.
Because of a long queue in our national hospital in Nairobi, patients are booked 2 years later for radiotherapy, and a few of them have been called to come for their appointment, only to be told by the family that the patient passed on a long time ago.
Actually, radiotherapy should be in every region, actually, because a lot of people are coming from one country. That's the problem. If at all the regions had kind of radiotherapy or chemotherapy, people coming to the surrounding would have been few.
In a continent of 55 countries, is it acceptable that 30 of them have no radiotherapy units? Is it right that some patients have to wait 2 years? And does it make sense that countries that do have machines only have a single outdated cobalt machine?
There's 29 countries in Africa where it's legally forbidden to import opioid drugs.
Human Rights Watch say that doctors who don't treat pain when they know how to do it and they have the drugs are the same as torturers.
C'est indéniable, les gens meurent dans la douleur parce que s'il n'y a pas de morphine, il n'y a pas de morphine.
The frustrating part of morphine availability in Africa is that it is not even an issue of cost. Morphine is literally less expensive than paracetamol or other over-the-counter pain medication.
It was $1 for 10 days treatment when we first started. It's now $2 for 10 days treatment.
I'm calling for them to allow morphine to be available for patients who need it.
The data is clear. Africa is by far the world's lowest consumer of morphine for medical purposes. Fortunately, many medical professionals are realizing the importance of palliative care and joining its ranks.
When I was joining palliative care, my colleagues here in Zambia Hospital, they told me it was suicide, it was career suicide. And I was like, okay, if it is career suicide, I'll go for it. And I found a lot of joy in palliative care.
The fact is that palliative care, notably oral liquid morphine when it is available, makes living with late-stage cancer manageable.
It is helping me a lot because when I'm not on it, I really feel a lot of pain. When I have it, I function well.
You can't interact with a patient who is in pain, and I'm not sure whether there is any relative who would like to see his own relative or her own relative groaning in pain.
It is, however, important to remember that palliative care is so much more than pain control. Patients and their families depend on palliative caregivers to give them holistic support.
The care you give to a patient and their family, when the patient dies, family members used to come back and thank, and come and thank us that thank you very much. You were there for us. And I think that is one of the most rewarding things for me. When a patient has passed on, but family members then come back and thank us.
So we're going to visit Jovia. She's 20 years of age. She has full-blown HIV/AIDS and cervical cancer. She's become really ill in the last month. She's very near end of life. So hospice has been visiting her very regularly to make sure that she's comfortable and peaceful and that she has enough morphine and food and money for supplies. So we're here today with Nurse Rose Light, who is her main carer, and to check on her.
Yeah, my grandmother.
Your grandmother was named Jovia.
Yeah.
And you were born here in Kampala.
Yeah. There's a lot of dust, fake houses, a lot of diseases, everything. So, but me, I love Kampala because I grown up from Kampala.
How old are you?
Me? Now. 29.
29.
Yeah.
And how old's your daughter?
She's becoming 14.
14.
Me? Yeah, I have.
What kind of cancer do you have?
I don't know exactly. Maybe I say, cervix.
Cervix cancer?
Yeah. I don't want to miss life, my dear. I don't want to miss everything. You people, I don't want to miss you. I want to stay here looking after my child. I went to do some works because I'm still young. Yeah. Not even to look after him. But even these legs are paining me, but slowly. Yeah. This medicine are helping me very much. After 4 hours, I take 4 milliliters. So I thank God for that because I didn't know that I'll get it that early. I thank you people to come praying for me, to support me. And because I didn't know I would get to you people. That brother of mine, and there is another one for my daughter, but I'm the one looking after them. And you people need. I don't have someone who look after me. I don't have someone who care for me except you people. And people in an area maybe. But others I don't have. My mom died when I'm 4 years. She died when my mom is delivering him.
Access to health care still remains a big problem, not just in this region, but in the country and in Africa as a whole. People still cannot access health care.
For example, if someone has to travel 1,000 kilometers to here, the transport might not be adequate for them. And when they get here, the subsistence might be a challenge. So many of them decide to stay that side until when they die.
So the stories are almost identical each time, and each time the parents realize there's something wrong, but they're in a village far from anywhere. That's one of the hardest things in Tanzania is the healthcare tends to be centralized to the cities or the larger towns, and there's very little out in the villages. And so, we have children who come with very advanced disease, and you might think, oh God, if only they'd come, if only they'd tried earlier.
Transport is not the only access issue. More important still is the problem of affordability.
Nobody can afford those treatments because most of our patients pay their treatments cash. We do not have good insurance schemes covering our patients.
But what we've seen now, and what we've, particularly with the help of Pfizer, who's been extraordinary, is that they've allowed us to use some monies to buy generic drugs that we can get from other sources. And so you can treat someone with a non-Hodgkin's lymphoma with CHOP, for $400 or $500 total care. And $400 or $500 barely gets you into the door of most hospitals, let alone the treatment.
There is disparity, yes. There is disparity among those who can pay and those who can't pay. Because if you can't pay, then you have to go through the social worker. Sometimes even those who can pay will want to come and look like they cannot pay. And in the process, it makes harder for those who genuinely can't pay.
Now the question becomes, who should be doing all this? Who should be thinking about legislating, funding, or implementing solutions to Africa's growing cancer challenge?
You can never do it alone. Nobody can do it alone. The Uganda Cancer Institute here was founded in 1967 through collaboration between Makerere University and the National Cancer Institute in Bethesda in the United States. I think out there are people who are ready to help us, but we need to help ourselves first, and let them see that we are serious.
This world is not an island. We all need each other. So we have to support each other to make sure that we get there. And I'm sure if we can support each other and we get there, we'll celebrate together. So we can solve our African problems, but we need the Western world to come and support us as well.
If I had the 30-second elevator pitch with the Minister of Finance, I would try to make the argument that this is a good short and long-term investment in your economy, that having a larger, healthier population in the long run is clearly best for the economy.
As bad as not obtaining funds is dealing with officials and VIPs who choose to place their own interests over those of other citizens.
Il y a un magistrat, un médecin, un ministre, la femme d'un médecin, la femme d'un ministre, etc. On nous dit, est-ce que vous pouvez nous évaluer pour une évacuation en France ou une évacuation en Tunisie pour voilà un sarcome, voilà des parties molles ou un sein et que tu évalues et que eux, ils vont prendre dans le budget de l'État pour envoyer une personne, 30 à 40 millions, ben ça pose problème. Ça, c'est un problème philosophique, un problème politique extrêmement grave, puisqu'on ne met pas les gens au même niveau. Pendant ce temps-là, les gens, ils sont là, qui viennent des régions, qui passent la nuit dans la cour de l'hôpital, qui n'ont même pas les moyens du petit protocole de chimiothérapie pour se faire aider, qui vont courir à gauche et à droite.
It's because those who make decisions have the opportunity to send their friends and relatives out of this country. And that's where I'm saying, way back in the 70s, I said I will not send anybody outside. We have the expertise here.
Ultimately, Africa faces the same choices as the rest of the world to decide which priorities matter most.
I think we were expecting funds last year, but from what I was told, there were other pressing problems in government which came up, and the funds were diverted to that need.
Look here, if every African country has a national airline, flag carrier, and the airlines fly, and it is possible, why can't that be possible? It is possible.
Je suis fâché pour X raisons. Ben, écoutez, dans ce pays, quand on voit qu'on fasse des monuments à 16 milliards, alors qu'un centre anticancéreux avec tout ce qu'il faut, les équipements et tout, a été évalué à 16 milliards, voilà.
If you allocate 50% on military, why can't you allocate 10%, 15% on health? Because you need a health nation for any kind of development.
Pendant ce temps-là, ben écoutez, nous, on n'a même pas de fauteuil pour que nos malades puissent faire la chimiothérapie. Tu vois, des malades qui attendent au soleil pour pouvoir, vous allez voir vous-même, la salle où on fait la chimiothérapie, c'est invivable, c'est inhumain. C'est inhumain. Et pourtant, les autorités sanitaires sont venues, ils ont vu. Voilà. Est-ce que nous, en ce moment-là, on dit on s'arrête, on ne fait plus rien, on n'est pas content? Non. Nous avons des malades qui viennent tous les jours, que nous suivons, des malades que nous avons opérés, qui doivent faire la chimio, qui doivent, etc. On ne peut pas s'arrêter. Voilà. Donc, et quand on intervient à la télé, quand on intervient à la radio, etc., l'autorité dit on critique, que c'est trop, etc., etc. Voilà. Et ça fait mal. Ça fait mal.
Let's see if people who fight cancer in Africa daily are confident that they can stop the disease from swelling to the magnitude that so many fear.
On the continent of Africa today, I would put the problem of cancer on a scale of 1 to 2, if 10 is perfect.
There are places I visit in Africa, even in some places where these are major cities, and people, including healthcare professionals, do not really know about cancer.
We have difficulty defining the full cancer problem. When I say difficulty defining the full cancer problem, what I mean is the cancer problem in Africa may actually be worse than what we are saying.
So Felix is a little boy who came to us. So he came in July last year, and Felix had a kidney tumor called a Wilms tumor. It was in his left side. But when we did the ultrasound, I wasn't here at the time, so it was the Tanzanian doctors who figured this all out. Basically, he had a tumor in his kidney which had left his kidney, gone through his vessels all the way up through his liver and into his heart. And he had like a fist-sized tumor in his heart. And I would say even a year ago, we wouldn't have been able to cure this boy. But there's a recently returned team of cardiothoracic surgeons who've just come back from 5 years training overseas. And what we did was we gave him his chemotherapy to shrink everything down. And then we have a fantastic group of local surgeons here, general surgeons, who do the pediatric oncology surgery for us. We also have a visiting expert who comes once a year who's an oncology surgeon from Ireland. And that team of Professor Martin from Ireland and Dr. Zaitouni and her team from here teamed up with the cardiothoracic surgeons. So in one sitting, this little boy has his belly opened and his chest opened, put on bypass. Here in Dar es Salaam, here in Muhimbili, they took the tumour out of his kidney, or they took out his kidney actually, and they took the tumour as much as they could out of the vessels. Then they opened his heart and took the tumour out of his heart. And then they closed him all up. And as you can see today, he's still on chemotherapy, but we sent all those tumour specimens to the lab and they were all dead. So he has a very sensitive tumour, so this little boy will be fine.
We know areas where we could make a difference. We know what to do, and we've just got to do it.